I got my EDD letter,
Oh, okay.
and I just wanted to FaceTime you real quick if that was okay.
Un momento, por favor.
Okay.
Okay, Dave, how was that?
Looks good.
Okay. And you can hear me fine, correct?
Yeah. Okay. Yeah, we see your screen now.
Okay. You can hear me fine, yeah?
You perfectly.
Okay, good. Hmm.
Okay, I can FaceTime you. You said I can FaceTime you now?
I don't think Marcus know that we was hearing.
No, he doesn't know.
So I went and unmuted him.
How many people do we have on now?
I see 8. Well, 7 because you're counted twice.
All right. Do you want to give him a couple of minutes?
I think we could start because the time is valuable. I know we kept you really late last time, and Pam thinks we may burn you out, and she don't want to do that.
No, I think I'll burn me out. I'm okay. Can you just check my screen one more time so that I can see myself? So make sure I'm centered.
I see it.
Okay, I'm centered. Okay.
Whenever you're ready, let me know. I'll start the recording.
Okay. Let's give folk a minute. I'm okay with that. How many folk are on?
One additional person joined in.
Okay.
Somebody else just joined in. Awesome.
All right. Can they hear me now?
Yes, Erica, hear you.
All right. Good evening, everyone. We're just pausing just for a few moments to allow folks to go ahead and sign on. It's just after 7. We'll maybe give them a minute or so, then we'll jump right into this evening's discussion.
After you do your update, I'll unmute any. You gonna do the questions first, or do you want to do verbal questions first?
I think we'll go through the questions first. I think the people submitted some fairly common questions, which I think are important, easy to address.
Okay, then after I'll unmute everybody so they have a chance to ask their question. Hopefully they won't jump over each other.
Yeah. Yeah, we'll unmute them right when I get done with the questions. Otherwise, because the way I have this set up, I won't see them in the chat. Okay. I'm still unmuted, yeah? They're hearing all of this?
Yes, everyone's hearing you.
Okay. All right, let's go ahead and get started. All right, good evening again, everyone. Good evening, everyone. I hope that everyone's had a good day. The Southern California weather is really quite nice and making the shelter in place or being at home for those of us who are at home almost sort of like a vacation. So I appreciate the opportunity to be outside. Before we get started, I just wanted to, again, thank you all for taking the time and having the interest to educate yourselves and to share with others who are on the line your experiences and your questions and thoughts about coronavirus and actually how it's affecting us. As usual, I'd like to get started with a quick word of prayer by your heads. Most gracious kind of Father, we thank you again for another day, for the many blessings, the countless blessings that you bestow upon each one of us. Be with us now over the next half hour or so as we share and discuss the lessons learned and try to address some of the questions that folk have. Most importantly, dear Lord, we ask that you would help us to remain faithful in our trust in you and our knowledge that you are our salvation. In Jesus' name I pray, amen. Okay, today's update in our fourth installment will, as usual, go through some of the numbers that are here in both California as well as Los Angeles, just to kind of put things in perspective. And then I'm going to jump right into a few of the questions that were submitted over the last few days in the interim since our last meeting, as a way to, I think, address some of the things which I think are really on your mind. And then at the end of that, we'll open up for questions that people can unmute themselves, and we'll just take questions for the remainder of the time. Okay? So again, as a level-setting way of discussing this, I like to kind of remind people that we are still learning a lot about coronavirus or COVID-19. Again, it's called COVID-19 because the outbreak started in 2019. It's also called nCoV or novel coronavirus because it is a novel coronavirus, and coronavirus itself is a family of viruses. So nCoV is just really trying to talk about a very specific novel or new virus that we haven't seen in this family. It's also important to just kind of remember these different periods: the exposed, the incubation period, where the person who actually is susceptible has the virus then replicates in the person's body, and then begins to replicate to a point where it can be shed and become contagious. And that may then lead to symptoms, and there is a symptomatic period followed by another period after the symptoms which resolve, then the person becomes non-contagious. Now, again, looking at this, I just want to emphasize what I put in red is a period of time, even in a symptomatic person, that is contagious before they're symptomatic, and a period after someone becomes well, if they're symptomatic, where they still are contagious. So this also means that there are people who are asymptomatic for this whole period of time, which can be 2, 3 weeks, a month, where they have no symptoms at all and they're shedding virus. So again, this is so important. I want to emphasize why it's important to really safeguard yourself and safeguard those who are particularly vulnerable for complications around you. So while I may not have a really major complication and be relatively asymptomatic if I were to get infected, I could actually be shedding virus and expose someone who might be very vulnerable, get sick and actually require hospitalization or an ICU or even die from it. So it's not just about me, it's about we or us. Okay, so again, I just wanted to reemphasize that. When I showed you these numbers April 6th, we had 16,000 confirmed cases just 3 weeks ago in California and 385 deaths. And 3 weeks later, we have 46,000. So we've gone from 16,000 to 46,000, from 385 deaths to just over 1,800 deaths in 3 weeks. And so to the right, even though you may see that we certainly have kind of taken away or taken off from what we originally thought was this exponential growth, right? We've now flattened, and we can see even more so that we have flattened the curve. That doesn't mean we don't have new cases. We of course have new cases and new people who become symptomatic and even people who die from this disease, but the rate is actually more stable as opposed to an increasing rate day over day. So this is the most recent data as you look in California. And if you look at Los Angeles County data, the Los Angeles County data, which represents probably about a third of California's population, 1/3 to 1/4 of California's population, we represent just about half of the cases and over half of those individuals who died or who have died from this disease. So putting that in perspective, Los Angeles County is, relatively speaking, to California as a whole, California's hotbed. We're sort of New York City or of New York State, if you will. The trends are no different than what we talked about last week, but again, I want to underscore that it's extremely important to think about who's getting this, and not just people with comorbidities, not just individuals who are over 65, but a large number of people, as you can see, who actually have this disease, who are between 18 and 49 years of age. So that's most of us on this call, and then another 25 or 27% or so who are 50 to 64 on this call. Again, one of the things that people do not think about when they think about risk factors is morbid obesity. Very obese individuals are at very high risk, whether you have diabetes or hypertension or not. Being very, very heavy increases your risk because of the changes in your lung mechanics, as we talked about last week. And then this has been updated as well from last week, and it just shows sort of what's going on in the hospitals of Los Angeles County. This graph is from 70 hospitals across LA County, and you can see over the last 7 to 8 days or so, the number of people who are in the hospital who have COVID positive status are about the same or going down. So things are actually fairly flat. And if you look at those people who are under investigation, meaning those people who we send a test on, who are symptomatic, who we send a test on, those numbers have been relatively flat as well. So we have new cases, but the number of new cases isn't increasing day after day. These people actually, we have sort of a stable rate. And again, this is, I think, kind of important. So I'm going to jump into the questions, and I think these review of the data are very helpful in trying to answer some of the questions that we received. The first question is, are we already in the second wave of COVID-19? And the first wave already passed and unidentified? Okay, and will that matter for projections for the next wave? Well, first, let me just say that projections are just what they are. Mathematical models with a lot of assumptions, many of which may or may not be true or may not stay true over time. And so don't believe every projection or everything you read, but they are sometimes our best guess, but our best guess sometimes are way off. Having said that, as I did last week, I did talk about the difference between peaks and waves. And so to answer the question, are we in the second wave yet? The answer is no. We are still in the first wave. And what do I mean about that? Well, last week we talked about this when we looked at this graph. As you can see in the red, right, this is a peak. And because we've done social distancing, we've flattened that peak, but it's still the first wave of cases. And we are still here. If you look at the x-axis, 1 month, 2 months, 3 months, 4 months, right, we're still in the first months of this. And so we're still in the first wave. Whether we stay flat or go down still just depends on time. Right now, we think we're still in this flattened part of this curve. And whether we stay flat or go down off of that first wave or not just depends on over time. To have a second wave requires us to dip down, meaning have a decrease in number of new cases and new symptomatic people before you go back up again to a second wave. So we are still in the first wave. Whether that first wave is peaked or not, we believe that the first wave has peaked, and we'll see what happens if they lift some of the shelter-in-place orders, whether or not we'll sort of extend the rise a little bit, and instead of actually being sort of flat here, we'll actually sort of go up, or whether or not we'll stay flat for a longer period of time or go down. We won't really know that until we see what happens with people and their behaviors, okay? So I hope I answered the question. Again, looking at the trends in California, even though there are these sort of zigzags, and again, this is just number of new cases here, okay, just number of new cases, that's what sort of happens. You have a zigzag over time. So I think this trend in new cases, which is the graph to the left, really says that we still are flattening or slightly increasing. And if you look at the number of deaths, again, we're either slightly increasing or flattening on the deaths. So we're still in the first wave, and I hope this graphic really demonstrates that well. We're in the first wave, and we're not sure whether we've peaked, but we think we have. The next question, very straightforward question. Are all the hospital treatments for COVID-19, sorry for the spelling, the same, or do some hospitals have different treatments? And the answer for that is fairly straightforward. There are no FDA-approved treatments for COVID-19 per se. The treatments that we have in hospitals, if you're sick enough, excuse me, are largely supportive, meaning the majority of people who become symptomatic come to a hospital and we send you home to take antipyretics, to take sort of like our flu therapy, right? The over-the-counter flu therapy, things to help with your muscle pains and aches, things to help with your fever, for example. And maybe if you have productive cough, maybe even to deal with that. But you're really just sort of dealing with measures to decrease your symptoms if you go home. If you have to stay in the hospital, usually that means you have a complication that requires acute care. And the most common thing for that is support of your lung function, meaning oxygen. And so again, that's supportive care. Oxygen is supportive care while we're waiting for your body and the good Lord to heal you. This is not really treatment per se, it's really supportive care. What you've heard about hydrochloroquine or Plaquenil, there are sort of mixed reviews for that. As you know, there are some studies underway to see if it really does work, but so far the preliminary data does not show that Plaquenil or hydrochloroquine works in general to cure or to reduce the burden of disease for COVID-19 or coronavirus. There are other therapies which have been tried, including antiretrovirals for HIV and other cocktails. And again, so far, nothing has shown consistently that it works. So you may go to one hospital and they may give you access, or they may have access to some experimental therapy, or they just may be trying different things. But in general, all hospitals have appropriate supportive care. There are some very sophisticated supportive care therapies, like something called ECMO, which is a very technical, high-risk supportive regimen that only certain hospitals have for the most extremely ill. If you we have these available no matter where you go. What you really need then is just patient and the expertise of the physician and the team taking care of you. It's a good question. What about experimental treatments? How can someone who's interested in experimental treatment get one? The best answer to that is that most experimental therapies are being coordinated through NIH website. And if you're interested, you go to the NIH.website and the institutions who are involved in various treatment studies or trials. and then contact those centers to see if you can participate or see if there's one in your area, for example. So for example, I can tell you UCLA is involved in novel treatments for this. Harbor UCLA is actually applying as one of the treatment sites for this. Cedars-Sinai is applying for this. But just because someone has an available treatment or experimental treatment doesn't mean it's better treatment. And so be careful about exposing yourself to experimental treatments. But if you're really interested in that, probably the best place to start is the NIH website. Sometimes you can see this through the Department of Public Health website, but most of them are being coordinated through NIH. This is a really good question, a curious question. What's the chance of the virus getting into my hair? Not me, because I don't have much hair, but should I wash my hair daily? And so you've probably heard a little bit about this. And I'm going to answer the question first by saying, really, the chance of this virus getting into your hair, staying in your hair, and you getting infected from your hair is very low. And there are a number of reasons for this. First off, it's aerodynamics. And if I were to show you a picture of aerodynamics and the air around me, if I'm just sitting stagnant like I am now in a room that's inside and I'm in an infected place, yes, it is very likely as I'm sitting still that viral particles could land on my skin, my clothes, my hair, etc. The thought is that this virus is covered with lipophilic or fatty surface, and we have our hair, and like most things actually sort of are lipophilic, meaning they like to attract fat. Well, true as those statements are, what people forget is that live hair is live hair and tries to protect itself. So hair that's attached to the root of your head, your scalp, not weaves, sorry ladies, but live hair actually is coated with a material called sebum, which actually is an antiviral and antibacterial by itself. So for natural hair attached to your scalp, there are protective properties in our hair from our body, from our scalp, that actually are antiviral and antibacterial. So that's one thing that actually protects us from that happening. Our hair is also very porous, making it very difficult for the virus to survive as well, just like other porous surfaces. The other thing that makes it very hard is as you are walking outside or walking around, remember small viral particles actually are like the air almost that we're breathing. And they actually move around us in laminar flow, just like the air does anyway. And so it's much more likely that when you're walking through the air, that those air particles, even if they're coming out of someone's mouth while they're talking, are going to move right past a solid object in a laminar flow. Okay, so both physics and our biology make it very, very unlikely that this virus or the viral particle itself is going to land up in your hair or stay in your hair. Now, if you have some synthetic hair, albeit maybe expensive, or you have hair that's not synthetic, but it's actually no longer connected to a live scalp directly, it is attached indirectly, if you understand what I mean, ladies and men, then yes, that hair is now just like any other surface, synthetic surface or a surface like your tabletop. But that surface is still, even synthetic hair, is very, very, very porous. And again, unlikely for the viral particle to survive. So all these questions about the viral particle being on your clothes, being on your hair, or being someplace actually assumes, number one, that the particle can survive and thrive. And we don't have really any data yet that the particles that we've found, even though that they're in small volume, are viral particles that can actually infect you, even though we can detect them. It doesn't mean that it can give us an infection, that they're infectious. So not only do we have to have an infectious particle or enough of it, but it has to survive. And so I think the likelihood of that is fairly low. Unless you're a healthcare worker and you're working around patients who have this, then in that case, I would do something to cover your hair If you can't cover your hair, I would recommend washing your hair as often as you can. Okay? There's a really interesting article in the April 17th New York Times magazine. Someone wanted to read a little bit about this. Very smart guy wrote responses to about your shoes, your hair, even your clothes, etc., and even the physics, if you will, of kind of contaminating yourself. And I would interest you to read that article, the April 17th New York Times article, a very interesting article. Okay, the last question that someone submitted, and then we'll open it up really quickly, is the shelter-in-place order really working? And the answer to that is yes, but it really depends on what outcome you're interested in. So we did the shelter-in-place, like most other states, because we wanted to get a handle on the number of people who might get sick and overwhelm our health system. Surely, if we had hundreds of thousands of people getting sick or exposed and getting sick, once you do the math, we know that we would overwhelm our health system with the number of people who would need to be in the hospital, to be in ICU, or be on the ventilator. So for that purpose, the shelter-in-place order has really worked. Now, some of you may have caught a podcast or the news of two individuals who work in Bakersfield. These are two doctors who work in urgent care. They own like 4 or 5 urgent cares. They probably tested over half the people in Bakersfield themselves, and so they think that they're relative experts. And they've basically been going out on the limb saying, this shelter-in-place order doesn't work, we shouldn't be doing this, etc. And they've been sort of misquoted to a degree, but they do believe that we should be opening things back up. They don't comment on how and to what extent, but I do think it actually extends the conversation about what's going to happen in the next week to 2 weeks when Los Angeles County begins thinking about whether they loosen the shelter-in-place or the stay-at-home orders. Now, I want to remind everybody that if and when the shelter-in-place orders, the stay-at-home orders are loosened, that will not mean that we're going to remove the 6 foot or the 6 foot sort of social distancing. It will not mean that we're going to remove the masking. So all of those sort of mitigation factors will still be in place. We will just allow some people to go back to work. We'll allow people to go to the beach, for example, and do other things that they've been prohibited from doing. But the social distancing will still be out there. Whether we'll enforce it's another thing. And we'll still ask people to wash their hands. We'll still ask people to wear a mask. And so even if the social distancing stay-at-home order is loosened, social distancing with regard to a person will be the same and will not change. And so we won't know for sure whether or not things have worked or not worked really in terms of a second wave or a peak until we have time that's passed. Now, I wanted to show everybody about the mask as I did last week, but I didn't have a mask, and then we'll open up the questions. So here's my mask that I wear. This is the outside of the mask, and this is the inside of the mask. And for the outside of the mask, I keep my mask in a bag. And when I put it on, okay, before I've touched my mask, before I've touched the bag, I've actually done hand hygiene already, okay? Then I take my mask and I put my mask on, okay? When I'm adjusting my mask, I only adjust the sides of the mask. I'm not going to touch the mask in the front part of the mask. I'm just gonna make adjustments for comfort on the side of the mask. Then I'm gonna do hand hygiene again. Now, the purpose of this mask, because I have a surgical mask, is it will prevent air exchange going out because it's a surgical mask and a fair amount of air exchange coming in, okay? But the other thing this mask is doing, which it does just as well as a cloth mask, is it prevents me from touching my mouth and my nose. And because I'm wearing glasses, I can't touch my eyes. That's the real purpose of this. Now I'm going to take this off. Again, I try not to touch the outside of it, just the edges of it alone. Then I can store it in the bag. When I get done with that, I wash my hands. Okay? So just a reminder, even if you have a cloth mask, the cloth mask really won't likely prevent you from inhaling small particles. It will probably likely prevent you from ejecting particles very far. So the particles will probably go further, much more faster down to the ground with gravity with the cloth mask. But what the cloth mask will do is it will prevent you from touching your face, particularly if you're touching other surfaces. Okay? All right. Let's answer some questions that folk may have. So this is the time to unmute yourselves and ask any questions.
Dr. Harrington,
Yes.
can you use salt water to wash your nose out before the virus goes down to your larynx?
Yeah, so it's a good question. There's this question about if you can mute yourself real quick. So there's this question about the virus lodging into the nasal pharynx, the back of the throat, for a day, maybe 2 or 3 days, before it makes its way down to your lungs to cause more severe infection like pneumonia or acute respiratory distress syndrome. And we know that most viral infections start in the posterior pharynx. That's why people have sore throats. But it's not always that way, but oftentimes. As well as there can be the virus hanging out in the nasal mucosa in the back of your nose. And so the idea of lavaging or washing your nose out, or even gargling with salt water or Listerine, for example, sound like prudent practices. There's really no great data for sure that works, but common sense would say it's probably an okay thing to do. We don't know for sure because no one has studied it, but common sense would say it's probably a good thing to do. But remember that all these things have a little bit of risk. Gargling probably isn't a problem. Probably not too many people are going to gargle are going to also aspirate. So just be careful about that. I wouldn't have someone who's had a stroke, for example, gargle. That person may actually have a higher risk of aspirating. Likewise, if you're doing a nasal lavage, you have to be very careful in doing a nasal lavage because you can aspirate the lavage washing from doing a nasal lavage. So these are things that may not be a bad idea, but you really want to be sure that you're doing them and not increasing your risk of swallowing, aspirating, or choking. Okay? So just be cautious about the mechanism or the tools that you're going to use to do that. But there currently is no data, no study that's proven that nasal lavages will decrease your risk, although it may make sense, or that even gargling, even though there were some reports out of China that helps with hot tea or Listerine. So again, I would support or at least suggest that you guys be careful, be cautious if you do these things, and be sure that you're not going to aspirate or choke. And again, I would not do anything like that for someone who's had any problem with their speech or swallowing. Good question. Other questions?
Those have a question, you could do *6.
So, Dr. Harrington, this is Valerie.
Yes, I recognize your voice, Valerie. How are you?
Good, thank you. Did you see the video that I sent you today?
Yes, this was of the Bakersfield, the 2 physicians from Bakersfield, right?
Yes.
Yeah, I'm not sure how long you were on, but I talked a little bit about that a little while ago.
Sorry, I was late.
No, that's okay. The basic answer very quickly is that, these are guys who seem very reasonable, credible guys who have been taken care of and testing lots of people for coronavirus in Bakersfield. unfortunately, sometimes statements that are made by people are taken out of context, even for what they want represented. I think they believe that the data may be overinflated, if you will. I can't speak to that. I look at the data in Los Angeles County every day, and I'm on a call every day with the public health officials, as well as with 6 hospitals, including UCLA, Cedars, and the Department of Health Services. And I can tell you, people aren't falsely padding the diagnoses. People aren't being asked to label something COVID unnecessarily. So that was part of this. And so I don't think that's really a common practice. I do think that this idea that there are healthy people who we need to go ahead and let get exposed to the virus, or ultimately so we can have some sort of herd immunity if there is such thing that can occur with this, is a real opinion that people have. And I think that the majority of people are going to win with this opinion in the next weeks as Los Angeles County decides to probably lift some of their shelter-in-place orders, as other states are doing this as well in other cities. So as I said last week, I believe firmly that we need to have a plan to let people, our kids, otherwise healthy adults with low risk factors for complications, go ahead and get this, particularly if there is a possibility of developing immunity. But what we really need to do is make sure we educate people about the risk of spread. Just because I can tolerate it myself doesn't mean that I'm not going to take it and infect someone else who may have a complication. So I think we have to be wise and patient about how we educate and support people so that when we open things back up, even kids going to school, if that's the case, or whatever it may be, that we're educating people about who's at risk for having complications and how we prevent those same people from getting infected and having those complications, because it's those people who are going to overwhelm our health system. Not you or me, right? Not my kids. It's going to be some people that I may inadvertently infect. Donna has a question.
Can't talk because I have to. Oh, okay, you unmuted me. Couldn't talk before. I heard that pets can carry this virus too. Is that true or not?
So good question. Most of the data that we have right now shows that let me reframe your question, because there is, can pets carry it versus can pets transmit it? Okay?
Right.
So the question we have pretty good data for is that there is really no evidence, real solid evidence, that pets can transmit the virus to humans. Okay. Even though this originally we think came from bats and then made its way from bats to another intermediate vector to humans, there is no real evidence that a domesticated animal is going around transmitting this to humans. That said, there are some reports that domesticated animals have the virus or have had the virus. And again, the real question is not whether they have it, but whether they can transmit it. So what we know right now is that there is no real evidence, solid evidence, that pets can transmit the virus to humans.
Okay.
Great question. Because I think there's a difference between that.
Okay. On the back of that, my granddaughter lives with me, but her pet lives with her brother in his apartment, and she wants to bring him to my house for a short visit. So would that be okay? We don't have anything to fear during that?
I can't think of anything. I think you have more to fear from the person bringing them than the pet.
Okay. Thank you.
Yeah, good question. Any other questions? You can raise your hand on the Zoom. It's sort of a neat feature. Type in your question or unmute yourself, and we'll go straight there. All questions, any questions are great questions. Marcus
Okay. So I know I kind of asked a similar question last time, but I attended my school's online town hall, and I also have a conversation with my old RA, my room advisory for my school, for the
Yeah.
dorm. And
Okay.
they kind of made it sound like they were gonna try to open up the online living building, or online, sorry, not online living, on campus living
Mhm.
buildings, but they were still going to refrain from opening up in-person classes. Because I
Okay.
think that they said that they were going to gradually, in the fall semester, try to figure out how to get kids back into the classrooms, especially for classes like labs. But from a doctor's standpoint, since I fortunately do have the option of um, either commuting or living on campus, would you
Mhm.
suggest to hold off on moving in for the fall semester and just move in the spring semester, or would you say that it would probably be safe enough to move in the fall semester should it open up?
That's a great question, right? So the whole idea for sorry, I'm just doing this. The whole idea for colleges, um, sort of a complicated thing, right? On the one hand, there are two populations in colleges, right? One population are the students, right? And the students are pretty healthy. There are some students who have, risks, chronic illnesses, etc., for which I think they're going to have a process for being able to communicate some of that, right? I think that's going to be really important. Hold on one second. I have my son. Apologize for that. He was asking me a really important question I need to respond to. So they're the very healthy students, right? And some of those students may have to self-identify because they may be at risk for complications, right? So I think that's kind of an important thing to think about. But for the most part, most students will be pretty healthy, resilient, and one would argue, like from an immunology perspective, an epidemiology perspective, let the kids have at it, right? Let the young kids have at it. Why even try to have one person per room? Let 2 or 3, 4 people have a room. You're not going to be able to control them. There's no way. Even if you only had 1 or 2 people to a dorm room, I guarantee you, just human behavior, kids on campus, they will all commingle. So now what you need to really think about is, do we have enough resources for these kids if a certain fraction of them get sick? So, are the school health resources adequate enough, right, to support people who may get sick, to test people, or to trace that, right? That's the most important part of the student piece, which shouldn't be that hard. The second population are me, like the professors, the old folk, right? And again, the older those individuals are, they may likely have comorbidities, chronic illnesses, diseases, etc., and they will have a higher risk of getting sick. And you'll have a bunch of asymptomatic students, right, in class exposing these professors.
Mm-hmm.
And these professors, if they're older or frail, what have you, they're out. They have a higher risk of, being sick, hospitalized, or dying. So I think when people are talking about this, and we're talking about this at UCLA, I'm involved in those conversations every week, how we mitigate these two populations, right? And the outcomes for these two populations are very different with regard to their risk. And so I think there's going to be kind of a wait and see phenomena. The Department of Public Health right now are working with the Cal State system and the University of California system. This is the state public health director trying to, whether or not they're going to make firm recommendations about dorm living, in-person classrooms, etc. So I would say, it's going to be more to follow on that in the coming weeks. What's going to happen first is this. We're going to loosen, I guarantee you, our shelter-in-place orders. People are going to be left to their own responsibility to wear masks, right? To social distance, to wash their hands, to do all that stuff. And then we're going to watch in the following 2 weeks, 3 weeks, a month to see whether or not we stay flat in terms of new cases or deaths go down, or whether or not we see a spike. And if we see another spike and that goes up, that will actually inform and impact, I guarantee you, schools reopening, both campuses, dorm rooms, and definitely in-person classes. So what happens in May and early June will inform what schools do, as well as even other businesses for that matter.
Okay, thank you.
Yeah, good question. Other things. Let's see. Do you think that those are, oh, the question went away. Dave, I don't know if you could read that question. Someone typed a question in the chat.
Yes, the question was, do you think that those who are opening up their business too soon?
That's a real good question. And we talked a little bit about this last week. You know, Vina was on the call and we were talking about the idea of profits over people. And depending on how you look at profits and who's making that money or using those resources, one could say that profit and people can go together, particularly when you talk about local businesses. And I think that, you know, that's a very complex question. I don't know what the right answer is. I think that the right answer will be how prepared, how much we educate and support people so that they can open up businesses in the right way. So do we need to just open up all businesses right away? Absolutely not. Are there certain businesses that are going to be more ready and are closer to being more essential than others? Absolutely. Are there more businesses that are lower risk in terms of, you know, their contamination or risk to other people? Yes. And so I think that people thoughtfully should go through those sort of elements and begin thinking about which businesses make more sense to open up first with lower risk than other businesses. And then be sure that individual businesses and owners are educated about the safeguards that they can take to minimize risk to both their employees, which is really important, as well as their customers. So I think it's extremely important. And we're going to be looking to the Department of Public Health and the CDC and other experts to kind of help us with those recommendations. But I think no matter how it's sliced, we're going to be opening up a lot of businesses just because our economics, and I'm not talking about the stock market, I'm talking about the economics of living day to day, are going to be very difficult for many people who have food insecurity, house insecurity now, as well as in the coming months if we stay at this same sort of jobless rate. So it's a great question.
I have a question. Can you hear me, Dr. Harrington?
Yes, I can, Angie.
I have been following some of this footage on the meat plants and how there's a significant number, I would say, going, I guess, across the Midwest with these meat plants. And it may not affect most of us because we're vegetarians, but the order just went for all the meat plants to stay open no matter what. And we're seeing a significant positive testing. How do you see that affecting us, I guess, as a nation? I know we're going to cook our meat, and so that should mitigate some of that, but could that potentially be a factor?
Yeah, so it's a good question. And we've talked about this maybe 3 weeks ago, sort of like fast food even now, right? So what I would say remember about this virus, right? This virus needs live stuff to stay alive for prolonged periods of time. So let's be practical about our risk of infection, be it from something that you order from Amazon. And let's just say someone at Amazon was sick and sneezed right into your package. I know it sounds gross, but then they package it up and they box it up. And your inside package, say you bought some Modano Italian balsamic vinaigrette, or vinegar rather, right? Just something special you have to order, right? And it was packaged and someone coughed on it. And then they put it in a box, and then it comes to me, And even with Amazon Prime, it's still 1 to 2 days, right, before I get to open it. By and large, the virus that was in that box is dead. Okay. Even if the particle is there, it's not infectious. Okay. And if I want to take extra precaution, I can sit outside for another day or two. Okay. So the reason why I say that is because in the meat packing plant, this is why we have to kind of try to control the information. Your question is a great question. But again, I'm going to remind you, let's say there's a meat packer who's infected. They pack the meat, it gets packaged, gets shipped off. Before it actually gets to you, it's a week plus before it actually gets to you. That virus is dead. Okay? Just because I can detect a particle, again, that's not the same thing as it being infectious. The virus itself is not infectious, it's dead. So I wouldn't worry about that in our food stock. No, nor would I worry about, Elsie or my kid who says, Dad, can we go to Chick-fil-A? And I got some people who are working at Chick-fil-A. Yeah, they may have masks, whatever, but they're asymptomatic people, and they touch this food or they touch the bag, right? So I'm not worried about that. So far, we have not a single case reported from transmission in that matter. I'm talking about someone getting sick. Again, this is so important. What you're hearing on the news is detection of the virus, not transmission of the virus and making someone else sick. Always separate this, right? So someone actually being tested positive, working in the industry, the question is does their work product or the outcome now make someone else sick? That's different than me and another coworker getting sick because I'm around a coworker versus the product, which is the Amazon box, the mail that gets delivered to us, or food, right? From a restaurant or food from a store that you buy. You're going to get sick from going into the store from someone who is sick. You're not going to get sick from what you purchased from the store. Okay? So great question. Trying to dispel some of that myth is, I think, very, very important. And I just went by Trader Joe's, by the way, before I came home. And I think dispelling some of that myth allowed me to buy some of my favorite items, which for the last few weeks weren't even there. Like there was food on the shelves, right? As opposed to everyone panicking, buying all this food. And I think as we dispel some of these myths, people are being a little bit more normal in their purchasing habits. So great question.
Thanks, bro.
Yeah. There are a
Dr.
couple of,
Harrington,
yeah.
this is Donna again. 2 questions. When riding in the car by yourself with the windows down, should you wear a mask? Or with the windows up, I know it doesn't make sense to have the mask on. And question number 2, if someone is riding in the car with you, is it necessary for both parties or any of us to wear the mask?
So let me do the second question first, because it's pretty easy. If it's someone that you live with, say I'm driving with Elsie, Isabella, somewhere, they're not wearing a mask here at home. So I wouldn't have them wear a mask when, driving the car. But if I went to pick up somebody and it was somebody, I don't know who they've been around or where, et cetera, they may be an asymptomatic spreader, et cetera. Yeah, they should wear a mask, and I would wear a mask, right? And I would disinfect the cockpit, if you will, where they were sitting when they get out, right? Or have them disinfect themselves before they get in my car. So I think if you know them, if you're around them, there's someone with, no, of course not. But if it's someone who, I'm going to go pick up Keith Bradford, right? And yes, Keith, I trust you, but I don't know where you've been, okay? Keith's going to sanitize himself when he gets in my car, and as clean as he may look with no suits, I'm going to assume that he's dirty. When he gets out of my car, I'm going to wipe down his seat and wipe down the area that he may have touched, right? So again, as I've said before, try to create some sanctuary space in your home, in your car, and keep those areas clean. Think about it that way. The second question, and I don't mean to be too flippant with this response, but some of you know I have an old small car that's a convertible, okay? And I was thinking the other day, if I went out for a drive, it was a beautiful weekend, would I, put a mask on while I'm driving down the street with my top down? I was thinking about this. And then I had to look at myself in my own mind and say, you must be crazy, Daryl, right? So, no, I would not. First off, physics are such that laminar flow and the diffusion of whatever particles that are in the air is not enough to infect me. There is no information right now at all outside that someone's gotten infected from outside, from casual, when I mean casual, just transient, passing by. There's not a single case of that reported yet, despite the evidence of, we can detect this in the air, et cetera, et cetera. So there's all this theoretical stuff. There's no evidence that you're just walking by somebody, okay, unless that person turned to you, smothered you with kisses, and then ran off, or that person said, open your mouth, ha ha ha, and sneezed in your mouth, right? There is no evidence that people just walking by casually, that anyone's been infected from that or been sick from that. Likewise, the risk of someone doing this, walking by, this person's infected, this person's not infected. They walk by. The risk of that person getting infected is very low. The risk of you driving in your car with the window down or the top down is probably 100 times less the risk of this. So I would say, girl, let your hair down, let the breeze in your hair, let it flow, okay? If you got the top down or you want the window down, your risk of infection or getting infected from that is minuscule at best, okay? So great question.
We have two questions that have been typed in chat. One is a vaccine. Has a vaccine been identified yet, or is there any progress to it?
Yeah, so great question. Everyone's working on the vaccine like crazy. If you follow the news, they're interviewing Bill Gates, who is now a self-proclaimed viral vaccine expert, okay? He's talking more about this than anybody. It's very interesting. So what they're doing is that they've also already started some trials, but in order to do the trial right, remember there are 3 components to any trial. First is the basic science. That's already we've sort of sped fast through that. The second phase of a trial is safety, which is what we're doing now. And then the third is, does it work? So we're doing some vaccine research right now with regard to safety. And it will take months before we have the safety data back, and even longer before we have any what we call efficacy data back. So we're looking at 6 months would be a really aggressive time frame, but probably more like a year or more before we have a vaccine, if there is a vaccine that we can develop that will be widely available. So it's going to be some time.
Okay, and the last question is, you talked about physical distancing and reopening of business. Would you say, would you say that going to a beauty shop would be a high risk at this time?
Well, it depends on what we're talking about risk of. Your makeover, which could be a high risk situation, or infection. So let me just leave my comments to infection, okay? So from an infection standpoint of view, I'm sorry, those who know me know I joke a lot. So from an infection standpoint of view, again, like so many places, be it a restaurant, some of you may have seen there was someone who was in Atlanta who was interviewed, who was a beauty shop owner. And she was talking about a number of strategies that she put in place to minimize and mitigate the risk of infection in her beauty parlor. She only allows so many people in there. She decreased the number of chairs in her shop. You can't bring any personal items into the shop. She has a headband shield that's put over your face during the whole process of hair cutting and washing. Everyone in the shop is wearing masks, etc. I mean, a number of things that she did, which I think were phenomenal. And so you could compare that to a business owner who just opens up the doors, right, and has crowded beauty salons. No one's wearing masks. They don't wipe down counters. They sort of let it go. So what I would say the answer is it depends. It depends on how serious the owner has taken your safety and the safety of the employees. If they've taken it very serious, they're not exchanging dollars. So you make your appointment and you pay with Venmo or over the internet with a card, say for example. You can't even bring your purse inside. You know, someone who's giving you those sort of instructions before your beauty appointment, now you know they're taking a lot of precautions. The person who says, yes, I got a 2 o'clock opening, we'll see you then, and that's it, that place probably is a higher risk environment. So I would use your common sense and look at the sorts of instructions and things people are doing to mitigate the risk of employees and yourself. Okay, I hope that makes sense.
Okay, have another question. What
Sure.
about the Chinese study that suggests one person infected 8 folks in a restaurant? Researchers found that virus circulated through the air conditioning system.
Yeah, very, very hard to prove that. I read that same report. This is like, you guys remember in Washington several weeks ago, right? There was a choir that was traveling. And I think we talked about this a couple of weeks ago that some 30, 40, 50 members of the choir, all these young people, despite washing their hands and being careful, all these people, they sang together and they all got infected. And so the claim was, hey, they were being meticulous and careful, yet these people who were singing together, a large number of them got infected and came down with symptoms. So what I would say is, remember this. Whenever you have reports like this, you have to remember that there are usually common factors in the environment that are common outside of the environment. For example, if you actually have a restaurant and the restaurant is open, and that restaurant actually is serving full numbers of people, let's just say, for example, a busy restaurant over 2 or 3 seatings, as they call them, serve 200 people, 300 people, and 8 people became symptomatic. And what they had in common was they went to that restaurant. Well, there may be a common link, but they also live in the community where a bunch of people in the community were infected. And they may have also used the bathroom, for example, or they may have been in contact with the same waiter or waitress. Right, there are a number of ways you can look at this. We do know that there is viral particles that have been seen in circulation, but again, in air circulation. But again, we have no real information that those particles survive recirculation, live, and then can get inhaled and infect somebody. So I think from everything I've read that there's more information that there are common infectious risk factors that these people have in these scenarios, or a common vector like a server, for example, or they went to the bathroom and touched the same, nozzle for getting their hands dried or washing their hands. Something else was probably more common than blaming it on circulation. If it were circulation, and if this was a common vector of recirculation, what I can tell you is that this disease would be much more rampant because there are too many industries, not just restaurants, that use recirculated air in their plants, okay? Too many of them, too many businesses, even hospitals with positive pressure and recirculation would be a big problem. So I'd be very careful about that. But if that actually gives you pause to not rush back into a crowded restaurant, then I think that it served its purpose, right? I do not believe that as we go back to this, that we should go back to business as usual in restaurants with 6 to a table, squeezing in between aisles, etc. I think that if we're going to go back to restaurants, they have to thin out the seating, that restaurant owners have to actually be very clear about their servers being tested and being negative, as well as being masked, and that people coming into the restaurant are washing their hands before they even sit down. So I think there are a number of things that people will have to do to make restaurant areas very safe or safer. But I think this notion that this is just a disease that is spreading like measles almost is actually unfounded. If this were a disease that was spreading like it did in that restaurant, it would be more like measles. And we would have, for every one person who had this infection, we would have dozens, if not hundreds of people getting infected per one person infected. And we just don't have those numbers.
The other question is, what is the scientific status of determining what length of immunity is associated with antibodies?
Oh, wow. So antibodies and immunity is ongoing. I'm not expert. Immunology was my favorite class, but I'm not a virologist, immunologist expert. What I can tell you is just what I've read and what other people who are experts have talked about. And what you see is basically a sort of the spectrum of opinions. What do we know? What are our observations? Okay, so here are the fact-based observations. There are two primary antibodies that our body develops in immunity, IgG and IgM. IgM is an antibody that develops early that tells us we were exposed. IgG is an antibody that develops late that says that we had it before and we have long-lasting immunity for some time, weeks, months, etc. So what do we know about coronavirus and immunity? We do know that the SARS virus, SARS-1, as well as other coronaviruses, have immunity that can last for months, sometimes even a year for most people. We don't know whether or not the immunity for this virus is going to last for months or a year. What we do know from an observation standpoint of view are that there are people who've been shown to have immunity lasting several weeks to a month, meaning they've had antibodies detected for a period of time afterwards. We also know that there are people who had those antibodies that were positive who've been reinfected, okay? Now, a very few number of those people were infected and symptomatic, and we believe that those people were infected who had a very mild symptom course, meaning that they had like an upper respiratory tract infection and that was it. And that meant that the immunity that they built up was based on sort of a small dose of the virus. We talked about this last time, that the amount of virus that you get can influence how much disease or how symptomatic you are. So we know that people oftentimes who are more symptomatic may have more virus, and people who are asymptomatic or have mild symptoms may have had a very light exposure. And with that, it may mean that if you then get re-challenged again with a larger amount of virus, that your immunity or the immune system that you have that has a little bit of antibodies may not be enough. That's sort of the best we have right now. We are, again, still observing more people, doing more research to see how long the immunity will last, how much antibody response you need to be long lasting for that to be protective. Some of that's going to come off in the vaccine research as well. But what I can tell you right now is that the immune response to this virus is sort of all over the map, with the majority of people who were exposed being protected. So we know that the majority of people, there are always exceptions, the majority of people who've been infected and who recover from this are now protected for some period of time. The majority of people. There are some people who get reinfected, but the majority of people, it follows the coronavirus like other coronaviruses, giving you protection for some months, likely. There are a couple of more hands. I'm going to take 5 more minutes of questions, and then we're going to shut it down for Tuesday, April 28th. Okay. Shoot, I think we have 2 more hands raised, Dave.
Go ahead. Oh, I have a question regarding, the whole topic about people, I guess, being exposed to the virus before this quote outbreak. Is there any kind of information that being a medical professional, that would support this claim that people have been kind of exposed to this virus and therefore may have antibodies and may not experience the same risk as someone who hasn't?
Yeah, that's a good question. I don't know. That's almost a question taken right out of Trump's medical briefing conferences. I'm telling you, these are really good questions you got there, young man. But what I'll tell you is I don't know. Like, I'm not sure whether there's information to that. What we do know is that there is no information. This is why the novel is attached to that. There is no information that this particular virus and the genome or genotypes have been sequenced, that this virus was present before 2019. So whether it was in the summer, whether it was in October, whether it was in November, I don't know. But we know it wasn't 2018, right? That there were a bunch of people who were exposed way before. So it's very possible, just because of the way viruses spread, that the first cases were in the United States before we knew about it. Because the only thing we know is when someone is symptomatic, right? We don't know about asymptomatic people. So it is possible, very possible, that there were people who were here, since the majority of the people who are asymptomatic are asymptomatic. It's very possible that there were people who were here who were asymptomatic before we had our first symptomatic patient. And that affords some immunity to this. I would just say on this whole issue of immunity, that in general, I believe, from all the information I've read and seen so far, is that we will have some protection if you get infection. The question I think that's outstanding is how long that protection will last. And I don't know. I don't think anyone knows whether that protection is going to last weeks, months, or a year and a half, right? Or more. So even if a vaccine will work, because if we can only get immunity for a few weeks, then the vaccine won't work, right? A vaccine only works if you get immunity that lasts for a year or 2 years, right? Then a vaccine has some utility. But if it only lasts for a few weeks or so, a couple of months, then a vaccine is of no value whatsoever. Okay, so it's a good question. I'm not sure I answered it, but that's sort of the best I have. Okay.
Thank you.
Yep.
Dr. Harrington, what I was wondering about, and I know last week you named the 3 things that we kind of need to have in place before we could fully feel comfortable or confident in opening up completely. Testing and I guess vaccine and good treatment. But I'm not asking you to, I guess, your educated thought about what would be the biggest factor or risk factor that would contribute to us definitely having that second wave, or that maybe the second wave even being worse than this one. I think that we're all probably gonna, like you said, follow some social distancing and do the disinfecting and wear the mask. But as they begin to loosen up and things, I guess, attempt to go back to normal, what do you see being the, I guess, in prioritizing factors or risk?
Yeah, so it's a good question. I mean, I think, again, let's just think about how people get infected. We talked about, this is a droplet disease, right? Touching things, or touching things and touching yourself, or inhaling droplets, particularly if you are a healthcare worker. So yeah, compliance with, wearing a mask, compliance with hand hygiene, very important. Whether this second wave or whether we have a catastrophe occurs or not, really is simply a numbers game. That's all, right? So for LA County, we have 11 to 13 million people. We have a proportion of those people who are vulnerable because they're frail, elderly, because they have morbid obesity, or because they have comorbid illnesses, so other diseases that make them at a higher risk for complications, like lung disease, et cetera, heart disease. So it's really a numbers game. How many of those people are susceptible and get exposed? That's going to be the single determinant on whether or not we have a second wave or a big catastrophe or peak. So the biggest risk will be how will we prepare and protect those vulnerable people. And that means, as I said, public health people are going to be smart about how they educate people, how they support people and societies and communities about trying to minimize the number of vulnerable people who are susceptible, who get exposed. That's our single most important, not just risk factor, but strategy, is using data to identify the people who are the most susceptible, the most vulnerable for complications, then educating, equipping, and supporting people, particularly businesses and other people, so that they don't infect or transmit the disease to those susceptible, vulnerable people. That's the most important thing. And I don't know that we have, I hope that we have strategic, thoughtful leaders who will be thinking this way, and that they will be poised and deliberate in their planning to make sure that business owners and communities are prepared for just that. If not, it's just a numbers game. No matter what we do, no matter how many masks we wear or how many times we wash our hands, etc., the virus will work its way through, and we will have a health system which is overran by sick people, and we'll have death tolls which are super high. So it really just depends on, again, whether we maintain the social distancing, whether we maintain the hand hygiene, we maintain the masking, and whether or not businesses and other people put into place mitigating strategies that reduce the risk to susceptible, vulnerable people for complications. So it's probably the best question anyone could ask, but it's one of the hardest ones to do. But if you think about that, it's the same question that you're asking, Andy, about this for the population. We should be asking about our families, right? We should be asking the same question. Okay, things get opened up a little bit. Now people are coming and going in my household. They're not on lockdown anymore. What am I going to do differently to keep my house more of a sanctuary, sterile sanctuary? What am I going to do to reduce the risk that someone who's coming and going, me, working, my partner, my children, people coming over to visit now, so I can reduce the risk of them transmitting something to me? So it's the same question, is my point. The same question you're asking about community or society is the same question we're going to be asking ourselves when things open up, because it's going to make us even more vulnerable to other people. So good question. I hope that's a segue to us thinking about what we're going to do for ourselves as well. Okay.
Thank you. Great answer. Thank you.
Yeah. All right. We are been past time. It's 8:15. You guys have asked tremendously wonderful questions, insightful questions, thoughtful questions, meaningful questions, which I'm sure were meaningful to everyone who was participating live, as well as those who might view this later, real time. So thank you guys for your participation and your question. We will have time again next week. You can submit your questions in advance or just write down your question now and save it for next week. And we will be sure to get to those questions real time. Again, thank you so much for your time, your attentiveness, your participation. And I hope that this was useful for you all. Let me close with a word of prayer. And again, I encourage you all to stay faithful in what's real and be safe. Bow your heads. Kind gracious Heavenly Father, we again thank Thee for the time spent, just in fraction of our time, to dutifully listen and study and edify our own knowledge and wisdom, so that we may be able to better care for ourselves and care for others. I pray that you will again continue to extend the comfort that only comes with the faithfulness in your power to each one on this call, and for those who could not participate in this call, and for anyone who might listen later to this podcast, that they remain positive, hopeful, and faithful as the most important way to buoy up and strengthen their immune systems and resist infection. Be with us as we go, and until we meet again virtually next time, stay in the faith and stay in love. Amen.
Amen.
All right.
Amen.
We'll see you all. Take care. And be safe. Thank you, guys.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
You're welcome. You're welcome.